Okay, so it's my pleasure to introduce Dr. Naj Soomro. He was actually selected as one of our Erskine Scholars for 2020 and who hopefully we will see in 2021. Dr. Naj has a number of different hats. He's a strength and conditioning coach with a keen interest in cricket. He's fluent in 7 languages, including English, Turkish, Urdu, Punjabi, Hindi, Sindhi, and Gujarati. Dr. Naj is a medical doctor with an interest in medical research and received his PhD in sports medicine from the University of Sydney. He has 8 years experience in clinical medicine, research teaching, and evidence-based learning and rural health. He has been a clinical educator and lectured in medicine at both Monash and University of Sydney. He's received a grant to commercialise research on sports technology to reduce cricket injuries. He's also a sports medicine consultant for the Pakistan men's international cricket team, but most recently has been based out of Bunbury Hospital in Western Australia, and Dr. Naj has been working on the front line in emergency medicine treating COVID patients, which we're going to talk about today. So welcome, Dr. Naj.
Thank you. Let's see if I can share my slides. Thank you very much, Carl, for the introduction, and thank you very much, everyone, for inviting me. So today I'll be speaking about should we exercise or not, and effects of COVID-19 on bones, muscles, and the immune system. What I will try to do is try to dissect the talk into several sections. And as we go along, we are going to talk about those sections in detail. So we'll initially start off with looking at the COVID-19 epidemiology and the pathophysiology. Effects on muscles and bones, and then implications in terms of exercise science. And then what I'll do when I finish off, I will leave the floor open to questions, and then we can have a bit of a discussion. So we know that COVID-19 is a part of the beta coronavirus family, and it's a subgenus of that. So we initially saw the outbreaks of SARS in 2002, which is again a beta coronavirus subgenus. Then in 2012, we saw the MERS, which is a Middle Eastern respiratory syndrome. And then in 2019, we saw the COVID-19, which started in Wuhan, China. The important thing over here is that our understanding of COVID-19 is at a very premature stage, and it's evolving as we progress. So new research is coming up. So some of the things that I will present in this talk are based on our findings and results from the previous outbreaks of the beta coronavirus. Some of the implications that we will look at will be also based on prediction and trends, and these predictions and trends can change as we go along in terms of the outbreak research. So this is a very interesting model that Johns Hopkins University runs live, and it looks at the world's live cases. And as of today, when I checked, there were 3.75 million cases with 260,000 global deaths. But the good thing amongst everything is the cases in New Zealand are actually tapering off, and we are hitting the flat curve, as we call it, in New Zealand. And also an interesting thing in New Zealand is that the death rate or the fatality rate under 70 is negligible, near to 0. So what are the clinical features of COVID-19? Essentially, in a case series published on 73,000 people from China in JAMA earlier this year, showed that 82% of the cases actually had no or very mild symptoms, like flu-like symptoms. And only 5% of the cases have severe symptoms which require hospital or ICU admission. Some data coming out of New York for 5,700 patients admitted to the hospitals showed that a large majority of the patients, 42% of them, had a BMI in the range of obesity, so 30 plus. And a lot of them, approximately 34%, had diabetes. So some of the comorbidity factors are factors that can predict the risk of developing COVID-19. But the interesting thing is amongst the lab features. So in terms of the lab features, we see lymphopenia, elevated liver enzymes, elevated LDH levels, elevated inflammatory markers, which include CRP, IL, interleukin-6, ferritin, elevated D-dimer levels, prothrombin time, troponin, elevated creatine, phosphokinase, and acute kidney injury. But what all these means in terms of muscle and bone are three particular enzymes that are essential. So that is lactate dehydrogenase, elevated inflammatory markers such as CRP and IL-6, and creatine phosphokinase. Now we know that lactate dehydrogenase is correlated to anaerobic exercise. So the higher threshold of anaerobic exercise we do, the greater is the lactate production. And lactate is also inversely proportional to fatigue. Directly proportional to fatigue. So the higher levels of lactate result in more fatigue. That means that we are unable to exercise. Similarly, CRP levels and interleukin-6 levels are elevated post-exercise. And essentially, creatine phosphokinase, which is a byproduct of muscle breakdown, is also elevated after an intense bout of exercises. So all these three factors, which are elevated post-exercise in COVID-19, are innately or at baseline are already elevated. Some of the case series, again published, show a similar trend. So this was a case series from Wuhan, which showed 214 patients. And they divided the patients into severe disease and a mild disease. And they showed that approximately 20% of the patients who had severe disease also had skeletal muscular injury symptoms, which actually included muscle pain and elevated creatine kinase levels greater than 200. Again, similar findings were found in subsequent studies, which showed that if the virus was causing severe symptoms, that means severe acute respiratory distress, then the levels of creatine kinase, levels of lactate dehydrogenase, CRP levels, and D-dimer levels were elevated and were significant. In terms of looking at independent variables that predicted death once a person acquires COVID-19, some of the independent factors through Cox regression models showed that age was an independent variable. Fever was again an independent variable. Lactate dehydrogenase levels were also independent variables along with interleukin-6. And this was again the case in a subsequent study that was published in Lancet, which showed higher CK and interleukin-6 levels. So what I'm trying to get at over here, what I'm trying to say over here is that inflammatory markers are high when a person gets COVID-19. And these inflammatory markers have significant impacts on muscle and bone. And we are going to talk about that in the subsequent slides. So we know that when we exercise, there is a baseline bone remodeling that is happening in the body. So the bone is an organ which is very dynamic, and it results in breakdown of bony mineralization, which means that osteoclasts try to break down the bone, and at the same time osteoblasts try to do the bone formation. And at three particular time points, this process is exaggerated and working really fast. That is number one, in childhood and adolescent, where we have growth spurts. Number two, when we do strength training and high intensity training, which causes a lot of strain on the bone or stress on the bone. And then the third one is fractures. And fractures will also cause this bony remodelization and remineralization process to be elevated. So let's talk about that a bit more in detail, because I think that will be an important thing that we have to discuss. So if you have a look at the levels of these hormones, we know that athletes who develop stress injuries, bony stress fractures, as we call them, have very high levels of creatine kinase and high levels of lactate dehydrogenase, which basically means that anytime these levels are high, there is a higher risk of bony turnover, and there is a higher risk of developing bony stress injury. Now we know that in a lifetime prevalence levels, up to 40% of us will get a fracture. So at some point, in our age, in our lifetime, we are prone to getting a fracture. And once that happens, it's important to understand how COVID-19 can affect it, because some of us as clinicians work with people in terms of their rehabilitation and getting them back to their baselines. So let's talk first about fractures and the process of bone healing. So we know that fracture healing goes in 4 phases. Phase 1 is the inflammatory phase. Then we move on to phase 2 and 3, which is soft callus formation, that is soft bony tissue formation along the fracture line, trying to cover that. And then the phase 4 is remodeling. So essentially what happens is that because the baseline characteristics of COVID-19 are such that the inflammatory markers are already high, phase 1 can take actually a longer time for the inflammatory markers to go down. Therefore, fracture healing may potentially be delayed if somebody has had a contact with COVID-19. Let's look at a few studies which actually show that. So this is a study in which hip arthroplasty was done in middle-aged adults, and it showed that the levels of C-creatine kinase were significantly higher post-surgery. So first 2 weeks, the levels of creatine kinase were significantly higher as compared to controls. And after 2 weeks, they taper down to the baseline. Similarly, interleukin-6 levels. So this is a study that was done on long bone fractures, comparing them with healthy adults who did not have fractures. And we see that the levels of interleukin-6 2 weeks post-fracture were significantly higher, and that tapered down after 6 weeks. We also know that pharmacological inhibition, so drugs that inhibit or reduce inflammatory markers such as interleukin-6 and creatine kinase and other inflammatory markers, can potentially improve the healing time. And therefore, NSAIDs may have a potentially beneficial role, although they have their other side effects. Similarly, in another study showed that lactate dehydrogenase levels were correlated to osteopenia and osteoporosis. So higher the lactate dehydrogenase levels, the higher the risk of developing lower bone mineral density. So we know that creatine kinase, lactate dehydrogenase, interleukin-6, and a myriad of other inflammatory markers are raised in COVID-19. We know that their levels need to go down for the first phase of inflammation to finish and bone formation to occur in terms of the callus formation and bone remodeling. Therefore, potentially bone remodeling and healing may be affected if somebody has had COVID-19. All right, so let's talk a little bit about muscles. Although there is a breadth of information in terms of looking at studies that look at COVID-19 and myopathic conditions and the effect on muscles as such, but the data is evolving. We know that from previous outbreaks and in the current outbreak, patients receive high doses of steroids, and the steroids cause a significant effect on muscles. So after a week of high dose steroid use, we start seeing preferential atrophy of type 2 muscle fibers. And type 2 muscle fibers, as we know, are the muscle fibers that are fast twitch, so involved in doing high intensity activities. And therefore, these steroid-induced myopathic changes include protein degradation and reduced synthesis, and including altered catabolism, therefore reducing the muscle mass in itself. So in terms of medication use, we know that we will get some sort of myopathy after a person has been admitted to the hospital and started on steroids. So this was an interesting study that was published after the first outbreak of SARS. And what they looked at is cadaveric specimens of 8 people who died of the SARS. And then they looked at the autopsy specimens under light microscopy and found out that 50% of them had focal myofibril necrosis. So 50% of them developed focal myofibril necrosis, and these are the people who died. So essentially what has happened is that once they're admitted to the hospital and they have developed severe symptoms, they are given high doses of steroids. The steroids work in turn causes myodegradation and myofiber necrosis. which in turn increases or prolongs their hospital time and rehabilitation time. And if they are unable to get out of that vicious circle, then that leads to death. So we know that there is some sort of linkage between the virus and the pathophysiology and effects on muscles. A lot of depressive things. So last week, our government reduced the sanctions, as we say, of getting out of the house. So I try to go out. And this is actually the annual Salmon Run that goes on in Bunbury. So just off the beach, I caught 2 5-kilo salmons, and then I fried them and ate them a couple of days ago. So essentially, the way Salmon Run is that they start off somewhere down in South Australia, and for spawning, they go all the way along the southwestern coast of Western Australia to a place called Rottnest Island, where they breed. So it's easy to catch them because there are millions and millions of them going across. All right, so given the pandemic, there has been a lot of panic going on. And one of the main things that has happened is that we have been told to stay at home, and for obvious reasons, which we understand. But what has also happened is that there has been a closure of recreational activities. So closure of the gyms, closure of tennis courts, football courts, closure of joint organized physical activities. And the question turns up that should we be exercising, and at what point and to what level should we be exercising? And the answer to that comes through understanding the immunity. So if we understand the immune response to exercise, we should understand whether or not we should be exercising and how we should modulate our exercise activity. So the immune system exercise has effects on our immune system, and it has effects on both the acquired and the innate immune system. However, in the interest of time, I will today be talking about the acquired immune system, that is a cell-mediated immunity, which works through the T cells and the suppressor and the helper T cells, and the humoral immunity, which is basically a pathway that generates antibodies against certain bacteria and viruses. So the response of the body to, in terms of exercise and the way it deals with immunity is interesting. So we know that if somebody is at a baseline, things will be pretty much straight. However, if we see at this graph, if you are exercising at higher than the sedentary level, let's say your regular mild to moderate exercise ability, then your immune function is quite high. So if you look at the curve that is on top, it shows that people who are exercising regularly at mild to moderate intensity, they have very good immune function. However, the problem happens when we start exercising or overtraining or over exhausting ourselves. When we start getting into overtraining, the immune function actually dips. So there's a transient dip in the immune function, and we can see over here that the immune function goes down. And when the immune function goes down, disease susceptibility, which is shown in the bottom curve, goes up. So they're inverse. So as soon as we start doing heavy overtrained exercise, then the immunity actually goes down and disease susceptibility goes up. So this is an interesting one. This study was done on 8 professional cyclists after they competed in a marathon. And they looked at their humoral immunity levels, which was basically measuring their T cells and antibody levels. And pre-exercise, the levels were measured. After the marathon, blood tests were taken at 2 hours and 24 hours. And basically what they found out, in the first 3 to 6 hours, the immunity levels were low. And then this transient dip in the immunity actually then goes away after 24 hours. And the reason for that is likely to be linked to stress hormones that are released by the body when we are exercising, and particularly we are doing high intensity exercise. So there is an increase in cortisol, there is an increase in epinephrine and norepinephrine, and there is also an increase in the core body temperature, which makes the body more susceptible to get, for the viruses to get an entry into the blood cellular stream. In another study, that was done on middle-aged females. So they got 36 middle-aged females, and they put them in who were sedentary at baseline, and put them into an exercise group. And the exercise group did 45 minutes of daily brisk walking, and the sedentary group continued the usual care. And they were looking at upper respiratory tract infections over the subsequent months. And what they found out that these women who were doing regular brisk walks for 45 minutes daily had a lower incident of upper respiratory tract infections, such as influenza type infections over the course. This was a seminal study because that led to other studies looking at the effects of exercise on viral load. And what we know that at moderate levels of exercise, one can develop their immunity and their immune response is good, and therefore opportunistic viral infections and transmission of those infections may be a little bit low, and the risk may be a little bit low. Similarly, they also showed a correlation between the change in the heart rate. So for this stage 2 of Bruce protocol, pre-exercise and post-exercise, they compared their heart rate change. And if the heart rate change was higher, that means they have adapted well to the exercise. The risk of upper respiratory tract infections was lower. Further studies have also shown this phenomenon. So we know that chronic exercise reduces illness severity and also reduces the viral load. And this has been done in a lot of different influenza type infections. But we also know that there are studies that have shown that the viral load actually goes down in HIV patients, viral load goes down in hepatitis C patients. I'll tell you an interesting story. And I was involved with the Pakistan cricket team, and this came up. So we had one of our players who developed hepatitis C, acute hepatitis C. He was taken out of the World Cup squad, and basically everybody told him, "You've got hepatitis C, you can't play." The player was absolutely asymptomatic, playing at elite level. I advocated him along with some of my other colleagues to get him back into the team because he was completely asymptomatic and the risk of transmission from player to player are negligible. So we got him into the team and he performed really well. So we know that, and in 6 weeks time, his viral load, and he was also taking antivirals, and his viral load went from 900,000 to 0 within 6 weeks time. We also know the example of Magic Johnson. So Magic Johnson was an NBA player of the league in 1992 and 1994. He was a player who had HIV. So we know that at moderate intensities, immune function performs really well when we are exercising. But we also know that that at very high levels, high intensities, then the immune function will come down, and you're more susceptible. I was actually having a look at some of the interesting simulations that have been coming through, and this company in the US has been showing us some simulations. I thought this would be interesting to share with you. So we know that 1.5 meters is considered as a safe distance when we are sitting together or when we are in close proximity. However, this changes slightly when we are exercising. So when we are exercising and running, the dynamics change, and because we are exercising, the wind pressure actually makes it a bit difficult. So what this company has been suggesting is when we are exercising, we should at least have 4 meters of distance from each other. I actually have missed on that. This is a different video. But anyway, so there are different models coming out, and I'll share a link later on. So moving forward, should we be exercising or not? Australian Institute of Sport is very clear. So they say that if you have been exercising and you're not affected with COVID, then you should continue exercising by yourself, not gathering in larger groups. However, things have changed a little bit over the past week. We have been given guidelines that we can get together in groups of 10 and exercise. So things are slightly improving as the curve is flattening. But the main question is, if you have COVID-19 and if you are confirmed positive with COVID-19, should you be exercising or not? And the answer to that depends on your symptoms. So if your symptoms allow you to exercise, I would advocate that mild to moderate exercise would be effective. If your symptoms do not allow that and you require hospitalization, then that's a different ballgame, and I would leave that to the hospital specialist to decide how much exercise you should be doing. If you're living in an environment which has a high burden of disease, which means that you are in endemic zones, let's say you're living in China, let's say you're living in the UK or Italy, then doing mild to moderate exercise is beneficial for you. As soon as you do high intensity exercise, your immune function may go down, and that may lead to higher risk of getting the infection. So the way you can work through that is possibly changing your workout routine. So rather than working first thing in the morning and then during the day, if you have to interact with people, then your risk is higher. Maybe you can change your workout routines in the nighttime, and then you go to sleep and your immune functions comes back in the morning. So those would be the sort of strategies one can work on. There are some implications in terms of orthopedic surgery. So those of you who are involved in physiotherapy, orthopedic surgery, or working in the hospitals, previous outbreaks have shown an important trend, and that important trend has been avascular necrosis. And essentially what avascular necrosis is that hip fractures are very common in elderly people, and this blood supply to the bone is really important for the fractures not to happen. And in terms of when people develop COVID-19, some of them have been shown to get avascular necrosis, which means the blood supply is reduced to the head of the femur, and that causes fractures of the hip. So this was an interesting case series that was published from China back in 2004, I think it was, and they observed 66 people who were admitted to the hospital and had joint pain, and 28 of them actually had avascular necrosis. So, and the other link to that avascular necrosis is also a high use of steroids. So that in the coming days and months, we may see people developing hip pain and hip fractures, particularly elderly people, those who have been admitted in the hospital, and that's one thing that we need to think about. But overall, in terms of take-home messages for COVID-19, our understanding of COVID-19 is evolving. Asymptomatic people and people with mild symptoms may actually have COVID-19 without knowing that. So if you suspect, make sure you get tested. Inflammatory markers are upregulated if one has COVID-19, and these inflammatory markers may have effects on the bone and muscles and in terms of exercise recovery. Mild to moderate exercise may be beneficial. However, high doses or high intensity training may have some detrimental effects if you're living in endemic region. Thank you. Open the questions.